Just want to welcome everybody. We have a couple more people joining, but I think just for timing purposes, we'll go ahead and get started. So my name is Melissa Gale. I'm a manager of NICU Family Support, and I'm thrilled today to have our guest speaker, Dr. Terplan. He is a board certified in Obstetrics and Gynecology and a Diplomate in Addiction Medicine. His clinical care and research focuses on the intersection of reproductive health and addiction. He teaches graduate students, residents, and medical students at the University of Maryland School of Medicine. So today he is going to be talking to us about science and drug scares. And what I'm going to do for everyone, I'm going to mute everyone's phones just to cut down on the background noise. And if you have a question during the presentation, go ahead and type it in. We'll likely save all of the questions for the end, but go ahead and type them in as you think of it, and we'll get to them during the course of the next hour. So I'm going to use the line. Just one moment.
The conference is now in presentation mode.
Okay, so Dr. Terplan, I'll go ahead and turn it over to you. So thank you so much for joining us today.
Well, thank you for having me. And hi, everybody. I've never done one of these things before, and I've actually never done a talk where I can't see anybody. And there's some parts from this that were designed to be somewhat interactive, and I'll just do all the parts myself, I guess. So we're going to talk about science and drug scares, in particular just about crack babies and how it sort of forms the narrative for some of the current media and even interpretation of science that we hear around, especially opioids and neonatal abstinence syndrome. Let's see if I'm able to advance the slide. Yes, I have a couple of grant funding for various things. And so I think everybody on the call is aware of this, that there's a lot of attention in the media for very good reasons around maternal opioid use and problems. And this is just one example of that. And as a consequence of all of this, I guess it was almost a year ago now, I was, actually I wasn't technically invited, but me and the Office for the National Drug Control Policy put together a meeting, a one-day meeting on maternal addiction, opioid-exposed infants, and neonatal abstinence syndrome. It was held here in what's called the Indian Treaty Hall of the Executive Office Building, which is right adjacent to the White House. By we, I mean ACOG, and I heard about this meeting just through the public announcement. So we registered to go and sit in the audience. It's a beautiful room. It's got this gorgeous tiled floors. I spent, it was, I guess the takeaway from the whole thing was I was the only obstetrician gynecologist in the room, and I was one of 3 physicians. There were some of the people who spoke are excellent, good people. I know them very well who are researchers in this subject area. Most of the audience were people from the criminal justice system, Hill staffers, etc. So at the end of the whole day, I kind of got up my courage to stand in front of everybody in this intimidating room and just to make a couple of points that I think had been not as emphasized as I wanted them to have been in an event like this. And these are sort of like the takeaway points for this talk and in general. And it's this idea that they were talking about maternal addiction, and actually this concept of addiction in pregnancy is an artificial construct. In that I've never taken care of somebody who picked up an addiction during pregnancy, an addiction as a brain disease that involves like a behavioral change. In fact, when we talk about pregnant women and addiction, we're talking about women who use drugs and alcohol, who get pregnant, who keep using. And most women quit or cut back. And so it's those who can't quit or cut back who continue to use, and that would be like the definition of addiction. But one of the good things that came out of this was that I actually got to meet Lynn Paltrow, who's pictured here, who's, you guys are probably aware of this. She runs a nonprofit called National Advocates for Pregnant Women. And through working with her a little bit, we got asked in early part of this year when Florida State convened a task force on prescription drug abuse in newborns to review the document. And there were some good things in the document. They also defined addiction as a brain disease. And they also created an immunity provision in Florida law for pregnant women seeking prenatal care or substance abuse treatment. That means that a woman who has presents pregnant for drug treatment is not going to get arrested for using an illicit substance or child abuse, or all the different ways that some women have been prosecuted around this topical area in the United States. But there were some real problems with this document, I felt. There were some quotes which were a little bit, misleading and wrong, such as it may be difficult to comprehend why a woman would abuse prescription drugs after finding out she is pregnant. I mean, that actually doesn't, that misses the concept of addiction as a brain disease. That would be pathognomonic for addiction, would be the continued use and the knowledge of harm. And they were really focused on, and I think this is important, training healthcare teams to cope with the emotions associated with treating drug-exposed newborns. However, there was nothing in the whole document focused really on the mother from any sort of maternal perspective, and we felt there was like an over-reliance on criminal justice solutions. So we wrote a letter in response. Oh, this was another thing too. They had some examples of messaging that I thought were really verge on blaming mothers for addiction, which is a medical disease. So we wrote them a letter, detailing our sort of positives and negatives of their task force guidelines, and I got this email back saying, thanks, we agree, and we put together this website. And so then when you go to the website, this is what it says. A baby's life shouldn't begin with detox, which basically, as you know, medication-assisted therapy in the form of buprenorphine or methadone has been the standard of care for opioid dependence over the last 20 years, and babies who are born to mothers who are on medication-assisted therapy will sometimes exhibit withdrawal symptoms, and so in some ways they are, throwing away 20 years of medical science, and some babies really, it'd be ideal if nobody could, but some babies are going to have to be withdrawn. So the reason why I bring this all up is because a lot of this narrative that we're hearing in the news and experiencing clinically has a lot of parallels to the crack cocaine time. And so I want to spend a little bit going through the crack years and especially focus on the relationship between the media and medical science, and use this as how to illustrate some very basic epidemiological points and pitfalls, and hopefully leave everybody with just like kind of like a quick way to read and understand some of the medical literature around the topical area of substance-exposed pregnancies. So we're going to talk about cocaine use in general, pregnancy in particular, and I want to sort of talk about how science informs society and how society influences science, and then those epidemiological points and pitfalls. So you might, about 100, 150 years ago, the prototypical image for a person with what we call now addiction was a woman, was an upper middle class woman who was addicted to like over-the-counter medications, usually or medications given to her by a physician to treat female maladies such as, hysteria, etc. Here are some other images. These are some examples of advertisements for some of these so-called patent medicines. That's a euphemism. None of these things were patented. And you can see that the audience for these medications were women and children. And the active ingredients in these things range. There was cocaine in them, there was morphine, there was alcohol, etc. This is actually the first image of somebody injecting a drug. and it's a woman injecting morphine. So the hypodermic needle was invented in about the 1860s, and people then started using it to inject drugs shortly thereafter, and women did so far more than men. That all changed with the Harrison Narcotics Tax Act, which is coming up to be almost 100 years old. That basically rendered substances that we consider illicit today illicit. And what this did was actually created a black market for drugs, and it really changed what a drug user was. So for most of the 20th century, unlike the late 19th century, the image of an addict was actually a man, usually involved somehow with the criminal justice system, and oftentimes, although this is not demographically correct, a person of color. And it really wasn't until crack cocaine that women and mothers sort of were figured back into the history of drugs, and that's kind of why it's so interesting and important. To talk briefly about cocaine, it was first described by the West in the 1500s. It comes from coca plants in the Andes. It's an alkaloid. It's from these leaves. You can see this is how it's sold in a lot of parts of Central South America. It was used in all sorts of different substances like you see here until the Harrison Narcotic Act, and it's actually sort of central to the history of medicine. Freud, who you could say represents the mind or in medicine, experimented with cocaine, developed an addiction to it, and his seminal work, Interpretation of Dreams, can be read as him struggling to overcome his addiction. Halsted, who then might represent the body, he was a surgeon at Johns Hopkins and is credited with inventing the modern academic medical training system, had developed a addiction to cocaine also through work sort of experimenting with it as an anesthetic. And he actually ultimately probably died of complications of addiction. The big change that happens is 1985, crack cocaine sort of appears on the streets in the United States. Because now I got bored in addiction medicine, I have to show this slide anytime I give a talk. This is a rat brain, and these are all the different receptors that have been described in the rat brain, but basically speaking, almost all drugs of abuse activate these dopaminergic pathways that go from sort of parts of the midbrain forward. You can see it a little bit more simply here on the human side. We don't know as much about the human brain as we do the rat brain, but it's the sort of yellow are the dopamine pathways. The drugs sort of enter in here, and this is true of all drugs, and they project to the frontal cortex. The neurons project to the frontal cortex. So that means that the substances mediate things such as reward, pleasure, things like that. Cocaine crosses the placenta, and hence cocaine use during pregnancy. The concern in the newborn in early childhood is primarily neurobehavioral. A brief detour on the differences between crack and powder cocaine. Powder is basically how cocaine enters into the United States. It's water soluble. It can be sniffed, swallowed, or injected. It can be converted into an acid, into a free base, so from an acid to a base, and it can be that people used to do this in the 70s, like Richard Pryor, who lit his hair on fire, unfortunately, when this ether wasn't adequately dissolved off of it before he lit it up. And then crack itself is actually a simpler way of making it, converting it into a base form. And it's not as pure as the free base. There's other sorts of impurities in it, and it comes packaged in little sort of containers. The main difference between these two is actually, this is always a question I ask, so think about what you think the differences are between the two of them. And the main difference is actually not addictiveness. They're both identical pharmacologically. They do enter the body, one a little bit more rapidly when you smoke, but the propensity to develop a problem to each of them is identical. Probably the main difference is price. Powder cocaine was, the champagne of drugs. It's what rock stars did, etc. And crack was cheap, and it's associated with quote-unquote inner city poverty, etc. And in many ways, crack cocaine is a marketing genius on the part of drug distributions. So instead of having to buy cocaine powder in large, 8 balls, which cost a lot of money, you can market it and sell it in small units that are, for just a couple of dollars. In terms of popularity, people kind of tend to think that crack cocaine was more popular during the crack cocaine epidemic than powder, but that's actually not true. In 1991, which is sort of the height of the, arguably the height of the crack cocaine years, more people in the United States had used powder cocaine than crack. Other differences have to do with how it's represented in the media. This is Al Pacino and Scarface. I mean, you Google cocaine and Kate Moss comes up. You don't have the same sorts of pictures for crack. Marion Barry, who was busted in a sting smoking crack cocaine, Amy Winehouse, those are really the only 2 celebrities that I can ever find associated with crack cocaine. So during the 1980s, there were several very big and popular TV shows. This one, 48 Hours on Crack Street, was the most viewed TV show in the mid-80s. NBC had something called Cocaine Country. The New York Times published a whole lot on the drug wars and drugs in general, as did the Washington Post. This is a little image of what was you could find in bodegas at that period of time. This was it's a little rose in there, but it's really to be sold as a glass pipe for smoking crack cocaine out of. I don't know if anybody is listening to this played video games during this period of time. I did, and at the end of the video games in any arcade, you would get this image would come up on the screen that winners don't use drugs. The sort of anti-drug message was really quite disseminated through society during the late 80s, early 90s, much more than it is now. It's hard to find these kind of don't say no sorts of things as much. I'm going to skip that. And sort of one way you can sort of see is these are 2 time covers from 1981 to 1986, and you can see how the national dialogue on drugs shifted in that period of time. High on cocaine, a drug with status and menace. It's not 100% positive, but it's a high, whatever you want to call it, like a cocktail glass. And then, 5 years later, drugs, the enemy within. So every year, they Gallup News has, Gallup took it over. It used to be New York Times, CBS News poll, asked people what's the most important problem facing the country today. In 1985, 23% said war or nuclear war. By 1989, 64% of people said it was drugs, and only 1% of people said it was nuclear war. You can see, since, in this last decade or so, drugs hardly is mentioned at all. When you look over here, this line here, you guys, I think everybody can see my cursor, right? This line here comes from Monitoring the Future, which is a study of high school seniors. And these are the percentage of high school seniors who report that they used any illicit drug in the last 12 months. And you see from 1986 down to 1990, that percentage has been was decreasing. The solid line is the number of New York Times stories that were about drugs and addiction. And the bottom line is the proportion of people in these polls who say that drugs are the most important problem facing the country today. And you can see that even though the use of drugs in society was decreasing, the number of people saying that there was a problem overall increased and tracked quite well to the number of stories reported in the New York Times. The takeaway point being that popular opinion tracks much more to media than to epidemiology or to science. So the question I had was, if public opinion tracks to media reporting, how about medical science? So one thing that we did was we looked in Medline, and we just searched crack or cocaine and pregnancy, and we graphed the number of articles that appeared per year. And we did the same thing with LexisNexis, which is a publicly available data feed of all print media. So it doesn't capture radio or TV and our web stuff. But so you hear the number of articles with the same search strategy over that period of time. And so these are both the same years layered up sort of on top of each other. And I'm going to go through a couple of kind of like events in the history of drugs. 1971, Richard Nixon declares the war on drugs. 1975, the Medellin cartel is formed in Colombia. 1979 is actually the peak prevalence for any illicit drug use in the United States. That means it was the highest proportion of people saying that they had used either in 30 days or lifetime use. Cocaine actually peaks a little bit later. 1982 is the peak prevalence for cocaine in the United States. And it's been decreasing kind of since then. 1983, Nancy Reagan starts the Just Say No campaign as her the thing that she's going to do while she's the First Lady. It really doesn't get very much traction actually until crack cocaine appears. Around 1985, crack cocaine shows up in Miami, LA, and New York City. Especially because of New York City. The New York Times is quite involved with detailing crack cocaine in the neighborhoods of New York, and they actually assigned a full-time reporter to the drug beat around that period of time. 1985 is also the first real publication around the topical area by Ira Chasnoff in the New England Journal of Medicine. I'll talk about that in a little bit more detail later. And you can see that it's not really until these sorts of things happen that you start to see sort of an uptick in media reporting, very low before then, and medical science follows a little bit after that. 1986, Len Bias dies from an overdose of cocaine, thought to be crack cocaine. In retrospect, it was probably powder. 1988, it's estimated from an article I'll talk about in more detail that there were 375,000 cocaine-exposed pregnancies in the United States at that point in time, and you can see then the medical science really takes off from that. Things really kind of shoot up. 1989, President Bush gives this Scourge of Drugs speech where he describes drugs as the toughest domestic challenge we have faced in decades. And this is also the first time the term crack baby appears in the media. And you can see from there, it's sort of things kind of plateau, so to speak, at a high level. So in many ways, this crack baby, if you look back, it really becomes the fuel for the crack cocaine panic, I think. And it's because, to a large extent, it's where the war on drugs and the war on abortion collided. And I'm going to show you some examples. These are some examples from the New York Times around that period of time. Never will I forget the pathetic sight of a tiny, stiff-legged, cocaine-addicted baby trembling nervously and crying for help. Here's a picture of a so-called crack baby. You can see that it's sort of swaddled and bound between two rolls. It was thought that these newborns were sort of hyperstimulated by the experience of, from the exposure to cocaine and needed to be tightly swaddled and held. People would volunteer in hospitals at this period of time to come in and hold the babies. There was also, which we can talk about briefly, like a border baby epidemic. And there are lots of these babies were born and were unable to be discharged from the hospital. The nurseries really filled up. Crack babies, the worst threat is to mom herself. A joyless view, even of toys. This is referencing some medical science here that the first studies of babies born to mother use crack, that they have difficulty relating to the world, making friends, playing, and even feeling love for their mothers. there was this real concern that these newborns who had been exposed to crack cocaine during pregnancy would be unteachable, that they would bankrupt the educational system. There were terms that were used such as biological underclass, lost generation, and the schools were really going to just be unable to take care of these individuals. So, to sort of summarize what these crack babies are from the from the media, at the time they were physically damaged, they were neurologically damaged, they're emotionally damaged, and that they can't feel love for their mothers. And this sort of describes a secret, like a whole bunch of stuff that's far more than teratogenic. So this is the first real thing that was published in New England Journal of Medicine from the Medical Science, 1985. They basically, among others, there were some comparison groups, not a horribly done study, but looking at 43 cocaine mothers who used cocaine, who tested positive for cocaine on labor and delivery. There were 4 abruptions, some sort of concerning scores on a behavioral survey, and that's about it. Probably the next big article that I mentioned before, I'm sorry this slide was supposed to be a little bit different. This is Ira Chasnoff, 1988. He took 11 Chicago area hospitals that had a 10% positive for any illicit drug rate. He then calculated if there are 3.75 million births per year in the United States, and we have a 10% positive rate, that means there are 375,000 crack-exposed pregnancies in the United States. I usually ask for people to give some comments on this, but I'm just going to say there's a couple of errors with this. One is that he went from any illicit to cocaine, or crack cocaine in particular. And the other is he assumed that the rate of positive is identical to the Chicago area hospitals as it is to the rest of the United States, which is completely untrue. Crack in particular had, and all actually illicit substances, have very unique geographies to them, and certain places have problems with certain substances that you don't see elsewhere. And Chicago was one of the higher prevalence cocaine cities in the United States at that period of time. And in retrospect, he probably overestimated this by a factor of 10. So not that it's a super small number, but probably at that point in time there are maybe 30,000 so-called cocaine-exposed pregnancies in the United States. A number of almost 400,000 gets a lot more mileage and scares people more than the real number. So that's what I call, like, you know, an error, what he did in his analysis. So this is sort of what we call the first generation of research, stuff that sort of happens in here with a big uptake, a whole lot of publication. Those are 2 examples that I just showed you. And this is some other things. Lots of negative findings were associated with cocaine from this period of time on all sorts of different organ systems and all sorts of different stuff. Here's another example of an article from that period of time. It was 74 newborns exposed in utero to cocaine, and they all got cranial ultrasounds to look at the presence of nervous system injury in terms of IVH, echo densities, cavitary lesions, and they compared this with the incidence of abnormalities in normal infants. 35% of these 74 had something abnormal versus 5% in the general population. And so the conclusion from this article was that cocaine causes central nervous system injury. This is also when I sometimes ask for feedback about, like, what do you think are problems with this article? And I will mention them. So think about it for a second. So one problem is the comparison group. It's comparing the incidence with abnormalities in normal infants. Are these, you know, is this a fair comparison? Probably not. The second is, you know, they were doing cranial ultrasounds. Was this blinded or masked, right? So did the person doing the ultrasound know that this newborn's mother had used cocaine during pregnancy? And the answer is no, that they weren't. So the people doing the ultrasound knew that mom had used cocaine. And they were, you know, watching those TV shows that I mentioned, reading the New York Times articles that I mentioned, and They were expecting to find badness, and yes, they did. And the third point is like what these different outcomes really mean. We know what IVH means, and we know that it's graded in a particular way that is associated with measurable, subsequent performance and stuff. But I don't know what an echodensity or a cavitary lesion is. And so these may or may not be of any kind of clinical significance. One thing to always keep in mind when you're reading medical literature is this, what we call the evidence pyramid. And this is a way of organizing research from sort of lowest level of evidence to highest level of evidence. And lower stuff would be, animal research, ideas, opinions, editorials, followed by case reports. Then you've got different types of cohort case control, randomized trials, and, systematic reviews or meta-analyses at the top. So most of this literature in the first generation are actually case reports or case series, and some are cross-sectional. And that's it. There's nothing in this upper level of the evidence pyramid from the first generation of research. So there's what I call the second generation of research, which this was way ahead of its time, that article, but really there's two systematic reviews that happened in the early 2000s. So there's three meta-analyses. Meta-analyses are taking previously published science, pulling it together, and coming up with summary conclusions. And what all three of these agree with is that there's no evidence that cocaine causes birth defects. There's no evidence of growth, motor, neurological problems when you compare them with other drug-exposed pregnancies, and only placental abruption actually remains associated with cocaine. This is an example of one of the meta-analyses, and you can see here, this is the pooled summary effect measure down here. These are the individual trials. This is when you compare cocaine versus drug-free, the outcome being major malformation. So there seems to be a slight increase in major malformations in the newborns who are cocaine exposed when you compare them to drug-free. However, this is now the same, looking for polydrug versus with cocaine versus polydrug without cocaine. When you look within people with drug and who used drugs in addition to cocaine, there's no difference. So the outcome, the conclusion being that the observed malformations in some of the earlier studies weren't due to cocaine per se, but were due to other unmeasured polydrug use, probably especially alcohol and cigarettes. One of the other things that came out of the crack cocaine epidemic was something called the maternal lifestyle study, which was begun in the early 1990s. This is the only prospective study of cocaine use in pregnancy. It was a matched study where 658 drug-exposed maternal newborn were matched with about 730 comparisons who were cocaine negative. And there's some very subtle findings. There's a slight increase in referral for special education amongst the cocaine-exposed children, and there's some differences in IQ, especially as the kids get a little bit older. They're right now, between 15 and 20. And we can, if you have questions, we can talk about those differences. I don't mean to actually minimize them. So basically, the conclusion from this so-called second generation of research was that the effects of cocaine are subtle, they're inconsistent, and they need to be understood in the context of polydrug use and within the caregiving environment. So I find this story really fascinating. You've got, from let's say 1984 to sometime in the 1990s, a whole bunch of medical science that shows catastrophic effects of cocaine on newborns and in childhood development. And then starting, sometime in the late 1990s until now, you've got people either doing prospective research or looking back and saying, you know what, we didn't really find. It's really the negative effects are subtle, they're inconsistent, and complex. So why is it? How is it that you can have one scientific discourse that differs so incredibly within, just a couple of decades? So Gideon Corin, who is an awesome person who runs the Mother Risk Program at Toronto Children's Hospital, looked back in 1994. He looked back at the all of the abstracts submitted to the Society for Pediatric Research, which is a big annual conference in 1989. And he compared accepted to rejected abstracts in terms of negative findings. A negative finding is a study that shows no effect, right? And then he compared the methodology of the studies, and he was just looking at cocaine. And what he found that with no abstracts with negative findings were accepted. So that means that people did research and submitted it in 1989, and they were looking at cocaine and some outcome. And they said, you know, there's not a difference with cocaine and this outcome. And every single study that had that negative finding was not accepted. And only studies with positive findings were accepted to the scientific conference. And then he went one step further and he looked at the methodology between these negative and positive studies, and his conclusion was that the methodology of the studies with negative findings was actually better. So this is what we call sort of a form of publication bias. This is another reason for why I think I spoke about this briefly that helps to explain how you can have these two differing discourses within one medical subject area. And they looked at 163 4-year-olds, and some of whom had been exposed to cocaine, some of whom didn't. They asked people, you know, through a whole list of developmental batteries to try and guess who was cocaine exposed and who wasn't. And the people performing the batteries could not figure out who was cocaine exposed and who wasn't. However, they were far more likely to label those 4-year-olds who performed poorly on the testing as cocaine exposed. So I want to review some of the methodological problems in this first generation of crack cocaine literature. Very few had any sort of comparison group. There was no masked assessment, so people weren't masked or blinded to the outcomes that were being measured. There was a use of surrogate endpoints rather than clinically meaningful ones. For example, echo densities in the brain. And there was no measurement or assessment of confounding, especially when you think about polydrug use and cigarettes and alcohol in particular. There was this positive outcome bias. And I didn't really talk about this, but there was an over-reliance on animal data, and there was this extrapolation from animal models to human behavior. And the one thing that we do know about cocaine is that lab monkeys are much more likely to use cocaine than those that are in the wild. So what I want to turn to now is just some basic epidemiology and how this scientific discourse can help us kind of walk through some basic principles. So the big question in epidemiology is exposure linked to disease. And it seems really, you know, straightforward, but there's all these problems with measure, you know. So if we're talking about drugs, and what is exposure? What constitutes use? You know, when do we measure? The first prenatal visit, labor and delivery? Is it self-report? Is it a toxicology? You know, all of these different ways of measuring it really change what you find. Really what we care about is exposure over time, but this is a very hard thing to actually capture. And then the outcome, what really, you know, if you're going to design the ideal study, what are the important outcomes and how do you define them? You know, are they birth outcomes? You know, sometimes. Is it developmental? Is it social? From a maternal perspective, you know, is our goal, you know, from a treatment or an intervention, is it abstinence? Or is it more, you know, like being employed, good maternal-child bonding, not being incarcerated? These are all things that you have to consider. And even though, like exposure and disease, that's the question, there's this thing called a confounder. And a confounder is something that influences both the exposure and the disease. And, you know, what we're really concerned with is causation and not association. And that gets a little, that gets actually, you know, tricky. So there's what's called Hill's criteria for causal inference. And that means, like, if you find an association, you know, cocaine being associated with birth defects, how do we know that it's a causal association and not for something else? And there's a couple of, if these are the criteria, that's consistent, i.e. there's several studies that show it, and meta-analysis is helpful in showing us where that is and isn't. That it's a strong association. The stronger association may be the more likely it's causal. That there's a biological gradient. That means more of the exposure leads to more of the outcome. Temporal sequence is very important, that the exposure precedes the outcome, that it makes sense biologically, and also that it's specific. Because it turns out when you try and classify associations, only a minority are causal. Many just happen by chance, or they're spurious, or they're confounded. But most of the associations that we measure in epidemiology are actually not causal. And it's really the causal ones that we really should care about the most. So I think what we learn is the importance of good science. And these are things that you want to think about when you read the literature on, let's say, opioids and pregnancy today. That exposure has been identified in a way that's nice and measurable, that there's a comparison group, that assessment was masked or blinded, that the outcomes make sense, and that other factors such as confounders were considered, especially smoking, and that you want to consider the level of evidence, right? Look at the study design and think about the evidence pyramid. Is this a meta-analysis or is this a case report? And then make your assessment of that study, but, relate to the level of evidence. So there are actually some very good things that came out of the crack baby epidemic. In 1989, there was only a minority of places in the United States that would take care of a pregnant woman for drug treatment, and that changed. One of the other things that changed too was not just funding for research and the establishment of the Office of Research on Women's Health, which may not have been, it was in the works for a long time before then, but with this importance in gender and the NIH trials. You might not be aware of this, but it wasn't until 1994 that anybody who received funding from the NIH to do research had to include women in their studies or make a very strong reason for why women were not included. Up until that point in time, women did not figure very much in the published literature, and especially pregnant women are actually absent. There's from government-funded research on drug treatment. However, there was actually some really negative consequences to both some of the bad science and the excessive media hysteria around this topical area. There are the border babies that we mentioned, labeling. So children being labeled as being crack exposed were treated differently and educationally. There was incarceration, which I'll talk about. There was also this is an organization that paid low-income women to get sterilized, which has been criticized for all sorts of ethical problems. Probably one of the biggest things that happened was the growth of the female prison population as a direct consequence of the war on drugs and crack cocaine in particular. The female prison population has grown more quickly than it has. It's grown more quickly among women than it has for men, and women are far more likely to be non-violent offenders than men, and most of the non-violent offenses are drug-related. Additionally, even though, in fact, white women use illicit substances more than black or Hispanic women, women of color are overrepresented in our prison system, and this is a consequence of sentencing disparities, which put people, had mandatory minimums for crack cocaine but not for powder, which really swelled the ranks of the prison population, especially people of color. And this actually sentencing disparity was not overturned until 2010 by President Obama. So I'm going to spend this last little bit of time talking about, briefly, about prescription, or about opioids in general. I think everybody is aware of this. The term epidemic has been attached to opioids. And just not to minimize everything else, but the epidemic really is one of overdose. And that's what the CDC has called the epidemic is from overdose. So here, here are the number of opioid sales from 1999 to 2009, and you can see it's gone up incredibly. And that mirrors the increase in the solid line, which is deaths, overdose deaths. And then as well as mirrors like the increase in treatment admissions. Right now in many parts of the United States, heroin is not the primary opioid compelling treatment admissions. It's prescription opioids. So with this increase, we've also seen like an increase in maternal use and especially neonatal abstinence syndrome. I think probably everyone is aware of this paper. It received a whole lot of attention for good reasons. We can talk about issues or problems with it if you want. And really what they found looking at this was an increase in this. This is looking at NAS amongst hospital births, an increase from about 1 in 1,000 to 3.5 in 1,000 over a decade, and similar increase in maternal opioid use per hospital births. The problem with this is actually, that's a problem, but the thing that got a whole lot of attention was the cost. So as we know, the most costly part of taking care of pregnancy is actually like the hospital period, especially the pediatric care. And the difference between NICU versus non-NICU is really what drives most of the cost. So if you look here, babies born with neonatal abstinence syndrome, the cost on average in 2009 was $53,000 compared to $9,500 for non-NAS births, and that's a huge difference. It's also distributed unequally across payers, and more of the babies with NAS are being paid for under Medicaid. So states, that's part of the motivation for states to get involved with this is to try and decrease costs. Sort of paralleling some of the what we're seeing clinically and what articles like this, scientific articles, are showing, I'm starting to see reporting, again in the New York Times and other places, which feel very much and sound very much like the crack cocaine stuff from the 80s. So this was an article in the New York Times a year ago, well, I guess now 2 years ago, and you know, they even mentioned, like the cocaine-exposed babies in the 1980s, those born dependent on prescription opiates are entering a world in which little is known about the long-term effects on their development. Actually, unlike the crack cocaine period of time where I think a statement like we don't know what the long-term effects on their development are going to be was correct, this is wrong. We actually have 20-some years of data on long-term outcomes of babies whose mothers were on methadone during pregnancy, and we know the answer to that question. So it's casting as if we've never sort of seen this before, which is the characteristic of a panic, actually, and is sort of incorrect. Here's another example. From the moment they are born, the babies scream inconsolably. These drugs are not safe for babies. They shouldn't be given to a pregnant woman because they have a devastating effect on their children. Again, this is like stands in contrast to medical science on methadone and pregnancy, and is an example of an overblown sort of hysteria. So I'm wrapping up. I feel like, in a sense, history is repeating itself. We had this whole arc of the cocaine literature going from horrible to really, much more than scientifically informed, to kind of nailing down what are the consequences and what they really mean, and they're small and they're subtle. This doesn't mean that they're not important, but they're not as catastrophic as were originally seen in science and media. And I feel like we're repeating that same sort of thing again with NAS, and it's kind of frustrating. So what I think that is important to take away is to really kind of think about the science, to understand that science is influenced by a social context, but the same idea to look at, when you read things, focus on what is the study design, what is the level of evidence, did they look at confounding, was masked assessment using, were things blinded, etc. And this is just like another big picture statement that I'm going to end with, which is a quote from this very good book called Pregnant Women on Drugs. It's an ethnography of pregnant women who use drugs. And I'm just going to read it. No other group of mothers lays claim to the unspeakable in quite the same way that pregnant drug users do. Even when women make substantial strides during pregnancy to reduce the risk of drug use to their babies, the image of an ideal mythical mother looms over these women's shoulders and over the shoulders of people with the power to determine their futures. And that's us. That's all, everybody on this phone call. Like, we're involved with these women, and we should really keep in mind that addiction's a medical disease that can be treated, and that we should try and steer away from sort of the stereotype, the scare, and the stigma that we see in especially the media right now. And that's it. I'll take questions.
Great, thank you. So if you have questions, please type it into the question section on your dashboard, and then we'll read those aloud. So go ahead and take a moment to type those in. There actually were no questions that came in during the course of your presentation. So
people can ask them if that works that way. I don't know.
Yeah, let's first see what comes in, just in case there's a fair amount of background noise. I guess one question that I have, in your work with these women, what do you anticipate as just a really good way to support them following the birth of their baby who was drug exposed?
Well, good question. So I think that a couple of things are really important, that all pregnant women, regardless of whether they use drugs or have problematic drug use, are concerned for the health of their pregnancy, their baby-to-be, their newborn, and their family. And so everybody makes some kind of behavioral modifications during pregnancy to try and maximize their health. Now, it might not actually always be the best decision that they make. I mean, I think I've taken care of women who try, and they want to go off the methadone, so they have to moderate some of the withdrawal symptoms by drinking alcohol. And alcohol, we know, is far more problematic for babies and pregnancies than the methadone is. So you want to educate them on those sorts of things. So you support them in the positive behavioral change. After birth, it's really important. It's actually a hard time for obstetricians in that a lot of people, this is going to change with the ACA, but a lot of the women who are on Medicaid might lose some of their health insurance. So we go from seeing them all the time to not seeing them a lot. And as most women actually kind of quit or cut back during pregnancy, but about 80% will resume their drug use afterwards. So it's very important to kind of make sure if people need treatment or want treatment, that they're in treatment and that we support them in the maintenance of their abstinence, like through the postpartum period. I don't know if that answered your question.
That's great. Thank you. So we do have a question. Let me pull it up just one moment. So Jane Latanzio is asking, other than methadone, are there any opiates that you are concerned can cause developmental issues?
Well, the two medications that we use to treat opioid dependence during pregnancy are methadone and buprenorphine. The reason probably the worst, if you want to pick the worst thing that people can use, would be something that they're obtaining illicitly, either heroin and especially if they're injecting heroin, because that's putting them at risk of infectious diseases, especially HIV through injecting, and either heroin or prescription opioids that they're obtaining illicitly. That puts pregnant women in contact with an illicit economy and puts them at risk of getting arrested, incarcerated, and being in jail is not good for family health. So that's, but I think comparing different types of opioids in terms of developmental outcomes, there were 2 articles in the last year or so which tried to kind of classify different sorts of birth defects based upon different types of opioids. I would read that literature with a great deal of caution, just because, again, it's a question of how was this measured, and what what these outcomes really are. I think what I don't want to see happen in the world is that women who are pregnant who, let's say, have to have an emergency surgery or for some reason have to be on an opioid for pain control, I don't want to see that being not given to them by providers out of a theoretical fear of some sort of newborn consequence. I don't know, did that answer the question? I don't know if that did at all.
Okay. I think you answered the question. Let's see. Jean says yes, so you're all set.
Okay, thanks.
So it's just a couple minutes left. Does anybody else have any questions? Go ahead and type them in.
And if anybody has any questions or anything, my email's right up there. Feel free to email me. I'm happy to, whatever.
Thank you. Well, nothing's come in, so I think that will be it for us today. But I just want to thank you again, Dr. Terplan, for sharing your experience and the viewpoint with us today. And we'll be sure to pass along your email address if anyone has any follow-up questions. So
great. Well, thank you very much.
Thank you, and thanks everyone for joining. Have a good day.